And we are happy to have Dr. Jason Beckrow give this lecture. This is one we've done a couple of years now. Vision of John Mulder's again as well, and very useful for having those conversations and talking with our patients and being very mindful of the language that we use. So I'll pass it over to Jay, and here we go.
Good morning, Joe. Can you hear me?
Yes, we can hear you.
Wonderful. All right, and we're pretty much right on time, 7:31. So we'll get us rolling here. Please, 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 as much as possible, let's turn this into a dialogue. I may not see if you raise your hand. I've got you over there. Slides are over there. Camera's there. We'll do our best to do that. But I would love, the more we can turn this into a dialogue than a monologue, the better. And I'm very honored to give you this lecture today. Part of the reason this occurred, John gave this lecture about a year ago. I'm guessing it was around this time a year ago. We talked about it significantly and profoundly. We used to meet after the lecture. We'd chat and do some of our pre-work for the podcast and things such as that. And we actually had planned to do this as a podcast episode. And so very, very, I think, important topic. So today, I haven't changed a whole lot of John's stuff. I have added some of my commentary and some of my slides, but largely today, my goal is to channel our dear friend and mentor and colleague, and kind of give you this lecture as he would want as we go forward. So very honored to be here. Let's move forward with some objectives. John wanted us to identify language that's used in charts and with advanced illness and how that can impact our patients. Highlight the concept of negativistic terms. Oftentimes in medicine, if the goal is for cure and cure only, we use terms that are negate that when that is no longer possible. And ask us to think about that and then how we can use our words even more constructively. To address the challenges of militaristic metaphors, right? Fighting a great battle, things such as that. And again, today, I love, my audience. We are usually the audience that is on the receiving end of some of these things. We join in midstream. But from time to time, I'm going to ask us to put on our hats if we were the primary care physician, if we were, the initial subspecialist, or maybe the ER doc or the ICU intensivist that made the diagnosis. So we'll try to, use different perspective. I've added a couple other objectives, recognize how our word choices and common medical phrases, they can influence a lot of things. I'm going to talk a lot about trust, empathy, emotional well-being, how we can impact suffering and things like that. Analyze the impact of our language, identify and replace potentially harmful or ambiguous words. Again, when do we use ambiguity because we just don't know, and when do we use ambiguity because we just aren't comfortable being more specific? And again, that goes for all of us, all of us. Apply intentional communication strategies. Again, I love learning about just the concept of communication. One of my favorite things in the whole world, if any of you have been to Walt Disney World in the last, 40 years, at Epcot Center, Spaceship Earth, it's the concept of going from humankind before language, the ability to share an idea. One cave person is trying to get the woolly mammoth, and then they signal to two other cave people. They come together, and as three, they're a team, and they can take on the woolly mammoth. And written language and the printing press, all the way to, well, gosh, just this morning I needed to get my slides to Susan. 15 years ago, I had to drive back and forth to pick up a flash drive, and today I could just email. So communication to me is fascinating. Communication is a huge part of our therapeutic toolbox to help our patients. And so let's think about our words and how they can impact our patients. I have no disclosures, but I do want you to think about this. Today's lecture is static. Hopefully, this lecture is appropriate for February 5th, 2026. But as we know, society evolves, our words evolve. Um, and so what I'm giving you today is static. Will it be the same a year from now? Much of it will be, but not all of it will be. So the topic is dynamic. So whatever we discuss today and wherever we land, let's not leave thinking, okay, we've licked it, it's done, and now we go for the rest of our career with these words. Let's think about the process and what words do we use today that are appropriate, that maybe not so much in the future. It can be a challenge. To me, I think that's kind of fun. What we do today is in fact static, but our lives, hopefully, and our learning is dynamic. These next few slides are mine, are things that I talk about a lot. Um, a lot of us on this call right here, and especially when I'm giving this lecture, like to house staff or to practicing physicians in the acute care setting, there's oftentimes a lot of fear of saying the wrong thing, of having the right intent, but it lands the wrong way. And my goal is to not get rid of that fear completely, but hopefully keep it in a healthy space. When fear is in a healthy space, that is motivation to grow and to learn, right? When it's overbearing, that's when it can become destructive and we fall back, or worst case, start to become defensive or worse. All right. So, what I have learned over time, and many of you have as well, and what I want for our fellows especially, and if there's any residents or med students on the call, we can sometimes use the wrong word, but hopefully have established enough trust that we can get that back. And so trust is a really critical concept as we aim to care for oftentimes, incredibly sick folks, folks with incredibly poor prognoses, sometimes folks that are maybe having the worst day of their life the day we see them. Um, I'm asked routinely, how do you build trust? And what I've come up with so far is my ABCs. I've added a G in there. I've got to figure this one out. But allyship. The more as I reach out, when I'm called to go do a consult, I need to remember there's a power gradient. I'm a physician. I wear a white coat. I have a badge. I walk in the room. I have relative authority, and I can do a lot of things with that. My top goal is to demonstrate to my patient and their loved ones, I'm here to be your ally. And there's ways we can be very intentional about doing that. Because until they know that, they're not sure. Worst case scenario, they may have been traumatized in the past, things that have nothing to do with you or me, the system at large, whatever it may be. And until they know you're your ally, they may, put that in a neutral position or maybe a highly defensive one. I don't assume that none of my patients trust me, but I assume that they may, and I need to earn their trust. So how do I demonstrate my allyship? I aim to build rapport. So many of you on the call that we've had conversations, I'll routinely ask you things that have nothing to do about the topic we're there to discuss. I'm called in to talk to a patient with metastatic lung cancer, bony metastases, just had a pathologic fracture, to do goals of care. Our first conversation is probably, where's home? Then they'll tell me the name of a town. I'm kind of a nerd. I'm kind of a trivia person. I probably know at least one fun fact about their town. If it's a town that I'm familiar with, do you know XYZ restaurant or this, that, or the other? The moment we start to build these connections, we go from being power gradient to now being partners. Allyship, build rapport. I do everything I can to cede control back to my patient. Sometimes just simply sitting down, putting my eyes beneath the patient's, giving them the position, right? They're above me. That's a physical thing that hopefully pays tangible value. And then lastly, this started out as a joke, but it's very serious, especially when I'm called into a consult in the acute care setting, usually in the ICU or some acute care, there's a lot going on, highly stressed. My first goal is, after I do my ABCs, is simply to get invited back. And again, that is predicated on the concept that we have enough time that I think the patient will be with us in 24 hours. Not always the case, but simply get invited back. And how I usually do that is at the end of our time, I will make a statement. Hey, I'll be rounding again tomorrow. I'll be on your floor probably between 10 and noon. Would it be okay if I stopped in, say, maybe 11-ish, plus or minus half an hour? I'm giving them the opportunity to say yes or no. 99% of the time, it's of course, doc. Occasionally, it'll be, hey, doc, my loved one from California happens to be a physician flying in on the red eye tonight. They'll be in around 3. Is there any chance we could meet at or after 3? You see how you give that control back to your patient. Once you get invited back, now we're building that partnership. So that's how we build trust. So we're going to get into some specific language. We should probably do another version of this lecture where those of us who are comfortable enough doing could do our blooper reel. Folks, I have said all sorts of things that seemed like a good idea at the time. That's going to be the title of my autobiography because so many things in my life, it seemed like a good idea at the time, went sideways. Thankfully, I got really good advice from my father a long time ago. He said, Jay, learn from your mistakes. It wasn't if you make a mistake, learn from it. It was, Jay, learn from your mistakes. Folks, I've made many of them. Many of our esteemed colleagues here have done the same. So we could probably do a whole lecture of things that I've said that the moment I could see, you can almost see the sound waves leaving my lips. And before they hit their ears, I wanted to pull them back, but I couldn't do it. So let's give ourselves some grace. Let's learn from these things, and hopefully you can learn from some of my mistakes as well. And this is all going to be predicated in the concept of suffering. Again, if you've rounded with me or worked with me, you know that this is the hallmark of my practice. I read this when I was a fellow, and I came away with the concept. Again, we need to recognize suffering in all of its component forms. Our best intentions sometimes can actually lead to suffering. Hey, I've got one more clinical trial to consider. Hey, we need to go to battle with this disease. Hey, they lost their battle with this disease. Again, suffering comes in a lot of ways. We can be wise to understand that and try to meet it in such a way that is uplifting rather than deflating. We can, as physicians, cure sometimes. We can relieve often, but we can comfort always. And a lot of times, it is, in fact, our words, our body language, our unspoken words. Sometimes, when appropriate, holding of a hand, offering of a hug. Again, when appropriate, offering, in a spiritual way. Would it be okay if I keep you in my prayers? Lots of things we can do that have nothing to do with what's the next drug, next dose, frequency, et cetera, et cetera, et cetera. Keep an eye on the time. 44. Okay, we're good. And this I've stolen from Tim Eyrig. So I'm just going to put it up there. You've seen it throughout the year. Sometimes just asking these questions, being curious, leading with that curiosity, seeing the humanity in your patients and recognizing, how you doing? It's a broad question, but man, you can get a lot of real estate covered with that. What's most important? What's most sacred to you? John's got the word sacred several times throughout these slides. What's your gut telling you? Are you anxious? Sometimes just validating. You ask someone, are you anxious? Are you nervous? And sometimes you'll get a firm no. Sometimes you'll get, well, of course I am, doc. Wouldn't you be? I mean, and anything in between. And when they're comfortable enough or trust me enough to reveal that vulnerability, it's great opportunity in there because when someone says they're anxious, I'll lean in a little bit and I'll say, you know what that means? And they'll say, what, doc? What does that mean? That means you're normal. And the moment you, with your white coat and your badge and your letters after your name and with that credibility, validate your patient, you let them know that what they're feeling is normal. Oh my gosh. Watch the trust meter, go up, tenfold just by asking that simple question and validating your patients. So now we're going to get into John's slides here. We'll kind of work through these. And again, I don't see any hands up or anything like that, but if you want, chime in. Would love to hear what you got to say. So this was from John's thoughts a year ago. The myths of sticks and stones, that words don't just describe things we do. Things we do, we make requests. how we as physicians give out warnings, invitations, all sorts of things. The medical care system isn't always delicate or empathetic. And again, I wouldn't say any of this is out of malice. It can be out of lack of awareness, lack of time, right? When I give these lectures to medical students, these are first and second year medical students, and they'll see these crazy scenarios. And of course, they would never do that, right? Because that's inhumane. Well, if you haven't slept in 3 days, you're in a busy ER and, it looks like a scene from the pit and all that stuff is going on. Sometimes we slip up, not out of malice, but it does happen. We need to own that. Hospice and palliative medicine practitioners are often called upon to care for people, as John says, who have been damaged by words. I agree, and oftentimes are going through maybe the most traumatic event of their life. For me, I see that oftentimes for our patients, it's like the equivalent of a car crash. And we are called in to, we can't fix everything. We got to be very mindful on how we establish our goals, but can we make it better? If we aim to at least hear the patient, validate the patient, meet them where they're at, now we can endeavor to make it better. We might not always get that Hallmark movie ending, everything just goes perfectly at the end. There's tears of joy and fade to black and the end credits. That sometimes happens. And that, can be a beautiful aspirational goal. Sometimes it's just simply if I can get from an anxiety of -10 to -5, that can be a win. Okay. But we're called in oftentimes at the most challenging times. And when we do this well, our colleagues will appreciate what we do, and our patients definitely will too. Okay. Here's one that definitely triggers me the way it did John. There's nothing more we can do. I was very fortunate that my first mentor, Carol, was both a medical oncologist and she ran a hospice floor in the Lansing area. And she basically said we never do that because here's the deal: we may not be able to offer the next round of chemotherapy. The cancer may now be outpacing the treatment. The treatment may be worse than the disease itself. And there may be nothing medically we can do to cure our patient of their disease. Doesn't mean there's nothing we can do. Again, sometimes it is just simply being present with your patient. We can always validate their feelings. We can aim to support the patient. So please, please, please don't ever say to your patient, there's nothing more I can do, at least not without highly qualified language. Hey, doc, I want to go for dialysis one more time. Hey, right now, that next run of dialysis is probably going to lower your pressure so much you may go into cardiac arrest. The harm is greater than the benefit. I don't recommend we do that next run of dialysis. The quicker thing to say is, hey, there's nothing more we can do, no more dialysis, and then I'm off to my next patient. Again, this is all predicated on having the time to make these conversations happen. So please, no more. There's nothing more we can do. It's very demeaning. It's usually spoken at a critical juncture. Again, not with malice, but sometimes we can forget. I read and boldened the word there, abandoned. Again, when our patients hear that from us, right? No, I am part of us. Joel Phillips is part of us. Aaron Young is part of us. You are part of us, or we, right? We are part of a big system. When we do this, our patients may feel abandoned. I know I'm preaching to the choir here this morning, but we need to take ownership that there's always something we can do. If it's just being mindful that I don't want to lead that feeling of abandonment. Very, very important. Clinicians, yeah, typically well-meaning and compassionate. All right, let's keep moving. Nothing more we can do. Consequence of the medical system. Again, if the only goal is cure, if the only goal is to return the patient to where they were when they were 18, that's going to fail for most of us on this call right now. I'd love to be 18 again. Probably not going to happen, and certainly not going to happen from something in a bottle. It is the default and expectation of practitioners, hospital staff, and families that disease-directed care will always continue. There's always one more thing, right? There's one more clinical trial to consider. If it can't be fixed, then there's nothing else that can be done. Big red X, baloney. Put a swear word in there if you want. I'm going to keep this as PG as I can. We must always be mindful that we treat patients, people that are part of families, communities, not just diseases, not just adenocarcinoma, right? Not just cell lines, not just genetic mutations. We treat people. I love as I'm doing this, I can hear John's voice. I'll try not to tear up, but I realize how much I miss John. So if you hear that too, I want that to just wash over you. All right, let's keep on moving. Nothing more we can do. Um, Sometimes our language, framed in the negative, right? The concept of withdrawing or withholding. It feels like we're taking something away, which is going to set up all sorts of dynamics, especially for patients who feel that they've been victimized before, which is most of our patients. Most of our patients who come into the hospital do not have hospital wings named after them. And so their position of power, economic power, political power, whatever it may be, is going to be challenged. And the moment I start taking things away, whoa, hold on, doc. Are you taking this away from my mom? Would you take it away from your mom? That's a conversation we can actually have because when the answer is yes for my mom, hopefully we didn't even make it to the ER and they're still at home with a hospice nurse and surrounded by loved ones. Do you see how sometimes we can miss, and if we have enough trust, we can pull it back? That's a very important goal. Let's emphasize what we are doing, what we can do. Instead of saying there's nothing more that I can do, here's what I can do. I may not be able to cure you of this disease or get you back to being a teenager, but what I can do is make sure that your loved one is respected, has their dignity. We've preserved their autonomy as fully as possible and have made them as pain and symptom free and done everything we can to relieve and ideally have eliminated their suffering. That we can do. Okay. I'm going to skip, I think, let's talk about prognostication. I've got a prop here. My favorite. I don't have a crystal ball. Folks, I do have a crystal ball. And you do too. You may not have one like this. This actually isn't a crystal ball. In fact, if I tried to read your fortune with this, we wouldn't get real far. It's actually a snow globe, and Tiger Stadium is in the middle there, and it's really old and it's starting to get nasty. But I just hold it up because technically I can say I do have, this is my crystal ball. I don't use it to prognosticate, but I would like you to start thinking in terms that you actually do have a crystal ball and can prognosticate. Because when patients are asking you, Doc, how much time do I have left? Doc, do I need to get my affairs in order? They're not asking for a date or a time, but what they are asking for is in your experience, in your best clinical judgment, can you help me hedge this? Right? They're looking for closure, and you do either physically or mentally have a crystal ball. And I encourage you to be as direct as you possibly can. Saying no one knows, God only knows. Again, when do we say these things because we feel they're valid versus this will help get me off stage so I can get to my next thing? Again, I recognize time is oftentimes precious, is limited. Let's be careful with the language we use. Because we do, in fact, have prognostic tools. John, I think what he was going for here is the concept of what I call hedging, right? I don't routinely give dates and times and have everyone here before Friday because they're going to be gone Saturday morning at 8 o'clock. But if I've got a patient right now, today's Thursday, and I'm not sure if they're going to make it through the weekend, I'm going to say, right now I'd put their prognosis in that hours to days category. Folks, if there's things you need to do to get closure, I would encourage you to do it sooner rather than later. It's, if I don't, it's Thursday and I don't expect them to be back on Monday when I return, I'm going to let them know that. I've done this enough times where I'm very comfortable saying, and I hope I'm wrong, right? I hope I'm wrong. And from time to time I am. If I'm wrong and I prepared the family that it could be only a few hours, they could be gone by midnight tonight, and I'm wrong, We celebrate that tomorrow came. Tomorrow can be framed now as a gift. But if I say, yeah, you should be fine, that family member from Florida, it's warm down there now, so yeah, they can probably wait till they come back Easter weekend. If I say that and I'm wrong and they pass before they come back, they're not. I've had an opportunity to help them get that closure that I have squandered. I want us to take accountability and ownership of that and use that in our language. So that's why I feel it's very important that we hedge and we give them the worst case scenario. So I will routinely say right now, if I think it's days to weeks, I will use language like, even though I think it's days to weeks, I want you prepared. Could something occur? Could they have a, acute heart attack? Could they throw a clot? I'm using language now that the patient, I think, would understand. They could throw a clot, and have a pulmonary embolus where they would die immediately. I need you prepared for that possibility. Right now, I think the likelihood of that is less than 10%, but I need you prepared for the possibility. And then I give them that range. So for me, it's imminently dying, hours to days to weeks, weeks to months. Okay. Avoid specific numbers. So again, that's my hedge. Um, and off we go. So again, please don't ever say you don't have a crystal ball because everyone on this call has done this enough times that you can kind of tell that, hey, let's see, it's February 5th today. They may be with us on Valentine's Day, but I don't know if they're going to be with us on St. Patrick's Day, and it would be a minor miracle if they're with us on Memorial Day. Okay? Be as honest and as open as you can. Some other themes. Yeah, he talks about current state and how we use clear or ambiguous language, right? Describing the current process, and using terms sometimes very purposefully. And I think it's important from time to time because when a patient's in the ICU, right, and they're on a vent and they've got an art line over here, they got a triple lumen catheter over there. They've got a urinary catheter. They're on dialysis. They're on three different antibiotics because they're septic. They're on three different pressors because they're hemodynamically unstable. We got all this going on. You can see the picture. Good news. The potassium improved by 10%. What's going to be led when that family member goes out to the waiting room and everyone's there waiting? What's going on? Hey, good news. Doc said the potassium is up 10%. So then we got to be very explicit. Patient is dying. Patient is at end of life. Not easy to do, important for us to do. Some unclear language, right? Using our own doctor speak. They're a high risk for mortality. What does that mean? Potentially terminal, grave. Grave probably is more meaningful to a lot of our patients than, high mortality risk. Critical condition, and stage. Again, these can be fairly ambiguous. Our goal as we build our trusting relation with our patient, what do you understand? Dial it in as much as we possibly can. Being very clear, there's our prognosis, hours to days. That's pretty gosh darn clear, right? Being again, without using, I predict it's going to be Sunday morning at 12:15. No, it's going to be, hours to days. But again, it gives us a range. Now the family member can take action based on that. Unclear language. Disease will take life in the future. May not recover. Again, a lot of language in here. How can we tighten that up? Patient is palliative. Comfort measures only. Again, a lot of these things have meaning to us. Doesn't have the same meaning to our patients and their family. Let's talk about negativism. All right, let's talk about, again, how can we start to frame these things and what we can do rather than what we're taking away? When we talk about a patient is doing poorly, I mean, there's a lot of objective evidence that supports, the ejection fraction has gone down, right? Their ability to perfuse has gone down. The patient's doing poorly. The patient's failing. Let's talk about the concept of failure itself, or success, because a lot of this is in how we define failure, success, and how we manage expectations. In fact, I was recently asked to talked to a family member. We had a really boy, just a tragic case, a young person, a teenager who had an osteosarcoma. They passed 2 years ago. They just had the anniversary, and the mother is has a very complicated grief. Very and part of that is the spoiler alert, the care the patient received was not perfect. Everyone who cared for this patient and their family did the very best they could, and there was no malice or anything like that. But sometimes we pick up on these things. And I was asked to call this patient's family member, knowing the energy, anger, just that's going on here. And so much of this, I was later asked by my chief medical officer, was there anything we could have done differently? What I came away with was, I mean, were there some minor things in the medical treatment that could have been differently? Of course, absolutely. But the outcome would not have changed. This young man had a horrible disease and was going to die and probably die a fairly painful death without some significant intervention and opiates and things such as that. But where we probably failed the most was in managing expectations. And a lot of times their failure to manage expectations comes from using language that can be ambiguous, misunderstood, this, that, or the other. I thought I heard you say. Right. So for a lot of us on this call, especially those of us who do, hospice work with any regularity, a lot of times patients will be brought onto the service and they'll hear, our sales reps are trained to talk about all the good things that we're going to do and lead with that. And sometimes the patient's going to hear, oh, I'm going to have a nurse at my house 24/7. And then they realize, no, I'm not. Hold it. That sounds like a bait and switch. Right. So we've heard these things. So a lot of this is in managing expectations. So failure or success first starts with, what is our expectation? How do we manage those expectations? If life is nothing but a series of zero-sum games, we're probably going to fail a lot more than we win. If in medicine our only proposition is we're here to help our patients be cured of their disease and live forever, we're going to fail at that 100% of the time. What if we redefine that goal? How do we help our patient? Remember, we can cure sometimes, but we can care and help, offer relief always. So if we change that goal from cure of the disease to now living as well as you can while you're treating the disease, while you're aiming to cure the disease, while you're living with the disease and the disease is outpacing the treatment as we get to that point to where the treatment is worse than the disease itself, can we aim to help the patient live as fully as they can? That's something we can be successful in. So again, I don't like the word failure. To me, again, this goes back to my dad teaching me, learn from your mistakes. When you learn from your mistakes, it is not a failure. It's how we learn. I very much, when I talk with my students and to all of you on the call here, especially our fellows and, junior colleagues, failure is part of a learning loop. We make a mistake. We go back, we deconstruct, we learn from it, and we do better next time. If we do that, we haven't failed. It's part of the learning process. So let's get rid of the word failure as best we can. All right. The instinct of doctors is that we feel like we failed when someone has died. Again, I think I'm preaching to the choir again here that most of us understand that's going to happen. How did we get there? Therein lies failure or success. Concept of giving up, that's a big one, right? And so a lot of times, when I'm with a student, and this goes with the there's nothing more we can do, right? So doc raises their hands, turns their back. I'm sorry, there's nothing I can do. Exit stage right, or even better, there's nothing I can do. Let's call the hospice guy. How's that going to leave your patient and their loved ones? I mean, can you imagine a more deflating experience? And yet it happens, practically every day. So let's not talk about giving up, especially for our patients. Let's not talk about giving up. When the patient is, it's got metastatic colon cancer, they're on oxaliplatin, in a triple cocktail, and they've got peripheral neuropathy from the oxaliplatin, right? Their immune system is through the floor, and now they've got, in the infectious disease process. They're nausea and vomiting. They're cachectic. They've lost, 75 pounds, and they weighed 175 to start. When they hit the pause button on the next round of chemo, that's not giving up. But in their minds, we, you, me, us, we can lead them to think that. So let's be very mindful with our words and how we try to undo that. Our patients are not giving up. They're making the best appropriate choice for the conditions. That's not giving up. That's actually moving forward. So how do we undo that? All right. So I don't like the concept of giving up or, again, withdrawing care. We're aiming to help our people live as fully as they can. Let's get rid of that. Oh, what happened there? There we go. All right, one more. Other language challenges. Do you want everything done? Well, that's kind of a silly question, don't you think? I mean, how many of us throughout our careers, you're in the ER, you're with a patient, it's time to talk about code status. Well, I know darn well, and I bet many of you do too, there's language I can use that's going to absolutely get me this answer or probably going to get me that answer. So now how do my biases impact this, right? If I say, do you want to live or die? I think that's in the slides, maybe the next one. Pretty simple question. I mean, I've got a lot of goals today. I've got a list here. I've got a list in the back of my mind. I've got a list literally on my iPad. Lots of things I want to get done today. One of them is at the stroke of midnight tonight is to not be dead, to be alive. So if you ask me right now, do I want to live or die? Pretty safe bet you know what I'm going to say. Under various circumstances, though, that may change. So do you want everything done? Do you want to live or die? Those are very, let's call them elementary questions. We can do better. Okay. Let's not miss the forest for the trees. A lot of times we're in the ICU and a lot's going on. And again, this is where the concept, hey, the potassium is up 10%. Let's not miss the fact that we're in an ICU and, any one of these things can tilt at any moment and we'll be running a code blue real fast. This is language I use when I'm oftentimes consulted, do we want to put a trach and peg in? All right, let's talk about things as honestly as we possibly can, and let's look into the future as best we can, crystal ball or not, and do the best we can for our patients. Other language opportunities. Learn their story. That's that trust building. When you can start talking about your patient or with your patient or with your patient's family as who they are, not just who they were, but who they are. They were a farmer, and I bet they loved getting out there on a beautiful summer day and doing X, Y, and Z. And if we could get them back to that spot, let's go for it. But right now, I think the likelihood of your loved one ever getting back on that tractor is incredibly low. And based on that, what would they want? Let's get to know their story. What did they do? What were their interests? Who did they love? Once we get to know them, we build, remember that building rapport, we can go a long way. Let's focus on the big picture. And again, this is less about death and dying only. This is about how we live well, right? Each and every one of us has a timestamp. 100 years from now, it's unlikely that all of us will still be here, which means there'll be a timestamp. What do we do with the time we're given between now and then? How do we couch reality and get to the truth? Again, the need for honesty. I think I've added to the slide in the next one. Remember, this is what I talk to my students about. Patients will always be as honest as they can. You ask a teenager who appears to be inebriated in the emergency department, have you ever drank any alcohol? And mom or dad is standing right behind them. The proper answer is probably going to be no, doc, never touched the stuff. Hey, mom and dad, we need you to fill out some forms over here. Could you go do that? We get on stage with that, teenager. Yeah, the truth is, off we go. If you're talking to a patient who has been abused and their abuser is standing behind them, they'll be as honest as they can. So that's from the patient's perspective. We we'll also be as honest as we can. And our honesty will be formed by our experience, our experiences. Especially, I don't know about you, but I think a lot more about my missteps and how I can do better going forward than about my successes. So I'm going to be as honest as I possibly can based on my own experiences, my own confidence, what I suspect the patient wants to hear, using my spikes, that invitation and what do they want to hear, meeting them where they're at. Um, so you need to be honesty is very, very important. Treatment versus cure. We need to talk about, especially so in my realm, when we're treating metastatic disease, the goal is to get to a state of remission, technically never a state of cure. But how I couch the language, my patients may or may not understand what we're going for here. But I need to meet them where they're at. And again, those euphemisms for deaf and dying kind of suggest that social or societal taboo. And a lot of times, too, it's our own neuroses or fears with that. So let's be mindful of what we bring to the table. Some more euphemisms, coded language, and stuff like that. Be mindful of the time. I think we're doing good. Communication is always a challenge. You put time constraints in there, it's a challenge. Electronic medical records, it's a challenge. Sometimes using this language, sometimes we got to cut right through and get black and white. Because again, these challenges are not just with our patients, but with our colleagues, our own team, sometimes with ourselves. Um, our terminology, patients' terminology, again, meet them where they're at. Um, What are we trying to say, and how can our words best convey that? Perhaps we need to move from right or wrong into helpful and non-helpful words. Again, a lot of this takes practice and things such as that. So again, I'll welcome any questions or dialogue that folks wish to have. Here again, John put that concept. This is a pretty simple question or silly question, don't you think? I'm willing to bet that most of you on the call today would answer this the same way I would, which is, yeah, I wouldn't mind another day, another year, another decade. Gosh, several decades. Wouldn't that be fantastic? Again, with good health and all that good stuff. No one wants to die. The issue is never if a patient wants to live or die. The issue is how they want to live. And can our support of the patient, can our medical treatment plans, can our medical systems support that? Or does it take away from? Does it relieve their suffering? Or does it add to that? And again, whenever we set this up in such a way that our patients feel that they're giving up, that's a big no-no. Again, that's why I love, for me, the word I use a lot is the concept of hitting the pause button. Huge difference between saying I quit and I'm going to hit the pause button. Got a patient with advanced, metastatic disease. The first treatment wasn't too bad. The second one, I was a little lightheaded, a little tired, but I was better after about 3 days. Third cycle, doc, I was in bed for a week, puking my guts out. Didn't care for that. Fourth, boy, doc, it just, I was in bed this whole 3 weeks. What are your goals? What's most important? What's most sacred? What's your gut telling you? Are you anxious? Based on those things, will this next round of treatment help you achieve what's most sacred? Doc, right now, what I'd like to do is get to the end of the month. My youngest granddaughter is expecting. I'm going to have my first great grandchild at the end of the month, beginning of March. And I want to be able to hold that child. And Doc, if you treat me right now, I know I'm probably going to be in the ICU. Can we hit the pause button? Doesn't that just sound a lot more palatable, hitting the pause button rather than saying I quit? It's an amazing gift that we can give our patients just with our words. John had this quote here, which I really love. Be kind whenever possible, and it's always possible. He quoted that from the Dalai Lama. And it made me think about a little picture frame that one of my trainers had up when I was in my residency clinic. And it was be kind for everyone was, excuse me, be kind for everyone is fighting a great battle. That was attributed to Philo of Alexandria, and I looked that up because I wasn't sure if I had the spelling right. In fact, I always had a Y in there. It is, in fact, an I. And then it said, ironically, that actually it is misattributed. So this is trivia now. I'm getting on a tangent, but I think we've got enough time to tell this story. Misattributed not only to Philo of Alexandria, but to Plato, right? What, second century BC. Philo of Alexandria was in the third century in the Common Era, but actually was probably first coined by a guy named Ian McLaren, who was a Scottish poet. So if you're at trivia night and you hear this quote and are asked what is the author, you got three things to go with there, and that might get you a free round of drinks for your table. So I hope that works. But if you don't remember these guys, try to remember to always be kind, for everyone is fighting a great battle, including yourself. Give yourself that that nod, right? That empathy. Here's the topic of honesty that John had. Be honest whenever possible, and it's always possible. I think be kind whenever possible. It's always possible. So John stole that from the Dalai Lama and came up with this. Way to go, John. Tip of the cap to you. I kind of stole this from one of my former deans. I didn't like how the dean said it. He said that patients always lie. I don't like that. So I coined patients will always be as honest as they can. And then ourselves, we, you, me, us, we, docs and medical professionals, we will always be as honest as we can. And let's face it, it's not always easy. If it were easy, we didn't have to have this lecture, and I didn't have to spend the last 50 minutes going over this stuff. All right, let's get into the militaristic. We've got 13 minutes to the bottom of the hour. Let's see what we can get through. We use a lot of battlefield metaphors. I do too. A lot of times when I'm giving lectures, you'll see a bookshelf behind me, and a lot of those books are history, which is usually the history of warfare, right? I've got a whole shelf dedicated to Civil War, Abraham Lincoln, and all that stuff. A lot of military metaphors, right? We're always fighting a great battle. And that can be fine, and it can be detrimental too, especially when we say we've lost the battle. Right? How often do you read or hear someone has lost their battle? Maybe you see that in an obit, things such as that. In a battle, there are winners and there are losers. In this case, it's disease. And here's the deal. Father Time and Mother Nature and gravity always win. It's like when you go to Vegas, the house always wins, all right? Father Time and Mother Nature, they're the house. And so if our goal is to live forever, guess what? The house always wins. Every one of us at some point is going to lose our battle with immortality. So to that, how do we define that? As John asked us, how do you beat dementia? How do you beat ALS? In terminal cancer, we love seeing those, patients were told a decade ago they had weeks to live, and here they are. Those are wonderful stories, very inspiring, gives hope to many. But we need to the reality is for every one of them, there's at least 99, if not 999 or more that didn't get to ring that bell, right? It engenders the specter of somehow the patient is responsible. That's huge too. When we put our position when we put our patients in the position to fight or quit, that puts it all on them. Let's transfer that and put it on us, right? There's a lot of room underneath that tent that is us. And how do we support our patients as part of that? Some people survive and do well. Is it because they fought a good fight? I've seen a lot of people fight, if you want to use that term. And you've seen, right? On paper, should be a good prognosis. And no matter what you do, it worsens and worsens. You've seen just some really bad luck. Doesn't mean the patient fought valiantly or didn't, right? Let's not add that insult into the injury that is the disease itself. All right. Some people die from their diseases. Is that because they didn't fight hard enough? I don't think so, and I don't think you do either. People cling to the language of battle. They want to be seen as a fighter. Of course, they want to be seen as a fighter. Sometimes hitting the pause button can be the most courageous thing a person can do. Um, let's not take that opportunity away from them. This further instills the ethic that if you don't fight, you've given up. Patients don't give up when disease is overwhelming their bodies. They're doing the best they can. We have a responsibility to help them with that. Encourage patients to think of illness as part of their lived and life experience. Help them to define what a fighter means. Because again, sometimes hitting the pause, but how do we empower? Educate our patients and their loved ones. Give them empowerment to make the choices that are right for them so they can begin healing even though they may not be cured. Direct the conversation such that the patient won't feel like they're the failure if the disease progresses. And some alternative perspective, advocate rather than fighter. Again, remember what they said at the beginning, this is a static lecture. Maybe we'll cycle around and again, battlefield metaphors will be more appropriate again, but the key here is forming that relationship with your patient, earning their trust, demonstrating your allyship, building rapport, ceding control, get invited back. And once you do that, now it's almost irrelevant. Once I've earned trust, I can say some things that maybe didn't land right and we've got high trust. Hey, doc, what you said back there, I didn't like that. Or oftentimes it won't be the patient, but a loved one of the patient. I'm walking out of the room, I'm walking down the hall. Hey, doc, come here, come here. When someone gives you that feedback, that's actually a gift. If I'm in a defensive position, it won't feel like a gift, but I wanted you to see it as the gift that it can be. Advocation, encourage people to advocate, rather than fight, assist with the values and goal setting. What would the patient want? They've lost capacity. Let's not fight to the bitter end just to be fighting. What would they want? And again, when you get to know the patient, who they were, who they are, would that person want these things? Because a lot of times when they see it in that light, right, they see their father, mother, grandmother, grandfather as who they were maybe a few decades ago when they were vibrant and active. And would that version of them want to be where they're at? And depending on that, it's not about fight or quit. It's a time to make sure that they're no longer suffering. And, if spirituality is part of the equation, which it routinely is, and if their beliefs are that they're going to an afterlife, who's there waiting? There's a lot of ways that we can very therapeutically and positively set this up for our patients. Okay? I think we're getting toward the end here. If you live the life you want, that you design, when your values are honored and your goals are based on what is, here's our favorite word, sacred and meaningful to you, when you die, you will have won the battle. I think that's very, very important. I guess I'm thinking of John right now. Give me a moment. I think John did this very well. So here's my wrap-up slide. Aim to earn the trust of your patient. Here's some references. And I think I'll quit 6 minutes early. Joel, I'll turn the floor back to you. And if you guys have any questions, I'll be happy to take those now.
All right, we were having some mic issues there. We're on now, so thank you, Jay, for that. And 6 minutes early is okay, because I'm sure we've got some questions and it's going to promote some good discussion. We're all in silent contemplation.
Good job, Jay.
We were so deeply moved that. Okay,
Yeah,
I'll
that's
say.
at the end there. I just, Joel, thank you for letting me do this. As again, I didn't want to tear apart too many of John's slides. In fact, I preserved John's slides. I just kind of added to them. But in the weeks that led up to this, I had a lot of contemplation and yeah. To comment here, I love the ICU asking families of children with medical complexity to show me a video of them when they're feeling well. Yeah, let's remember our loved ones for because again, those will be the memories we take with them. Maybe that's part of the whole deal here is I try to always remember when I'm with a family, especially when I'm called in, and many of you get this routinely too. You're called in by a colleague because the family is just being difficult, challenging. My favorite is how quickly we go to they clearly have a personality disorder, right? And they're oppositional, this, that, or the other. And if we just simply remember the person that's there making those decisions, hopefully it's a family, it's a team that's well aligned. Obviously, family dynamics happen a lot. But if we just try to remember, so in my image, it's stereotypically, it's an elderly woman who's caring for an older elderly man, and she's going to outlive him. And she now needs to make decisions for grandpa that she doesn't want to make. I need to remember that at some point, grandma is likely going to be at a funeral, a homegoing, some service of remembrance. And grandma needs to know that she did all she could. And that's where I and you and we have an incredible opportunity to help grandma process that in such a way that when the time comes, she knows she did all she could, if for no other reason because the doctor said so. Let's aim to always give that to our patients. I know that resonates with this crowd. It resonates with first and second year medical students. There's a lot of points in between those two poles. So we'll go forward and spread the good news.
Yeah, and I don't know. Can folks hear me?
Hey, Brad.
Oh, we have a feedback in here, but hopefully nobody else can hear that. These guys are fine. I'll just comment on Rachel Masak's comment about those kids. I agree. It's about the memories, but many times it's also about what the goal is for that medically complex child getting back to. And the number of times I've heard residents or attendings sort of have no idea what that child was really like outside the hospital is really mind-boggling. And I'll ask, well, are they at their baseline? And the team has no idea. And we have a really simple way to figure that out by asking the family. So those videos this is what our goal is get back to this. Maybe it's possible, maybe it's not, but it's really simple and common sense of asking that family who knows the child the best. And in rare diagnoses and disorders where I think we medical people think we know all the details, I've literally heard people walk into the room and tell parents, well, that's what kids with trisomy 18 are like. And I bite my tongue a little bit every time because I'm pretty sure that mom who's been caring for this child with trisomy 18 for 3 years knows really well what kids with trisomy 18 are like, way more than the person who just walked in the room. So I'm always amazed by the silly things that we tell families sometimes. And silly is probably a very kind word to use there. So I appreciate all this discussion and conversation. So thank you.
Thanks, Brad.
The thoughts going through my mind, thank you for triggering this, is I want you guys to look back sometime, look at the obituaries, read the obituaries of the people that you've cared for. And I'm always surprised about how much I didn't know about the person. And as I'm thinking about this, I wonder if there's a way to phrase a question so you can get to know your patients better. It sounds morbid, so I think we need to change it, phrase it, but what's your obituary going to sound like? Because what's in there is usually what's most important to those patients. And it's probably getting back to the meaningful and what's meaningful and what do you hold sacred.
Yeah. Joel, if I could piggyback off that, one of my favorite books of all time is Stephen Covey's 7 Habits of Highly Effective People. And I believe it's habit 2, begin with the end in mind. And that chapter starts
before you can get out of the car.
That chapter starts with basically you're at your own funeral and who would be speaking for you and what would they say? And his point is you get to now live your life in such a way that that would happen. Sometimes that's how we live well. And again, why I think John impacted us so much because he definitely walked the talk.
Well, good, and thank you, Jay. I know it's hard shoes to fill to take that lecture on this year, so I appreciate your help doing that.
Opportunity, Joel.